Hi everyone, thank you for tuning into this portion of the core competency presentations. My name is Courtney Sutton and I'm a NICU clinical pharmacist at Monroe Carroll Jr. Children's Hospital at Vanderbilt in Nashville, Tennessee. Today I will be presenting to you on micromanaging the micropreemie. I have no conflicts of interest to disclose for this presentation. I will use abbreviations throughout this presentation, so these are here for your reference. By the end of this presentation, I want you to be able to define micropreemie and review the complications associated with extremely premature birth, discuss strategies to prevent common morbidities associated with premature birth, and compare and contrast treatment options for the micropreemie population compared to other preterm infants. Let's begin by discussing what a micropreemie is. The term micropreemie is defined as an infant that's born before 26 weeks gestational age and has a birth weight of less than 750 grams. Oftentimes in the literature, you'll see this population of infants referred to as periviable births. The CDC reports birth statistics in a variety of ways, but by gestational age, the lowest age category is less than 28 weeks. And in 2020, those born less than 28 weeks accounted for 0.64% of all live births. When looking by birth weight, births less than 500 grams accounted for 0.13% of births, and those 500 to 999 grams accounted for 0.4% of births. While these are very small percentages, it amounts to more than 20,000 extremely low birth weight infants per year that require care in an intensive care unit for survival. There is a noted racial discrepancy for those births less than 500 grams, with a higher number of these infants being of Black race. Births that occur prior to the third trimester have a high mortality rate, accounting for around 40% of infant deaths. Survival of these infants born in the periviable period has improved. In the late 80s and early 90s, survival was reported as less than 20% at 23 weeks gestation, but greater than 50% at 24 and 25 week gestational ages. More recent data shows survival around 25% for infants born at 23 weeks and 40 to 60% survival at 24 weeks and 70% survival at 25 weeks. While efforts to improve survival have been made, reported survival in this population is variable, largely due to differences in prenatal care, maternal and infant care, pre- and postnatal treatment offerings, and when to suggest comfort care measures be implemented. Part of the variability in the management approach of these infants is due to the variability of ultimate outcomes. Wide variations in practice regarding resuscitation and active treatments at early gestational ages results in survival data that's difficult to quantify. That being said, it's understood that survival chances decrease with decreasing gestational ages, and those that do survive often do so with multiple long-term morbidities. A family-centered approach with open communication and discussion between the family and medical team is important for optimal decision-making when these periviable births do occur, as many families do not understand the typical course and likely complications associated with extremely premature birth. Infants that do survive this initial period are likely to do so with a high rate of prematurity associated morbidities. The rate of neurological impairment, including cerebral palsy, blindness, hearing loss, and developmental delays, decreases with increasing gestational age at birth. Moderate to severe neurodevelopmental impairment decreases progressively with each week gained of gestational age at birth. Most surviving preterm infants will have some degree of neurodevelopmental impairment, with up to 85 to 90% reported in infants born at 22 weeks gestational age. Additionally, many infants will have long-term issues with other organ systems as well. As I often describe to my learners on NICU rotation, the complications related to premature birth can start to sound a little like three-letter alphabet soup. Around 80% of infants born less than 750 grams will have respiratory distress syndrome, with about 50% of these infants going on to develop bronchopulmonary dysplasia. Sepsis also occurs in around 50% of these infants, and both necrotizing enterocolitis and intraventricular hemorrhage affect around 15% of the micropreemie population. So now we'll begin our discussion on prenatal management of these. In 2017, the American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine released a guidance document regarding periviable births. In this document, they discussed possible strategies to improve neonatal outcomes, either by delaying delivery or through antenatal interventions targeted at decreasing neonatal morbidity. The therapies addressed included antenatal corticosteroids, magnesium sulfate, antibiotics, and tocolytics. But the question still exists, do we have improved outcomes from these therapies? Antenatal corticosteroids are one of the best interventions that can be performed to reduce neonatal morbidity. In 2011, Carlo and colleagues enrolled over 10,000 infants born between 22 and 25 weeks gestational age with the purpose of comparing groups that received antenatal steroids to those that did not. Of note, the steroid group didn't have to receive full course of antenatal steroids. One dose was enough to include here. Infants underwent neurodevelopmental evaluation at 18 to 22 months corrected age, and they found that in the infants born at 23, 24, and 25 weeks gestational age, antenatal steroids reduced the rate of death, intraventricular hemorrhage, necrotizing enterocolitis, and neurodevelopmental impairment at 18 to 22 months. In the group of infants born at 22 weeks, antenatal steroids reduced the risk of NEC, however, other outcomes did not differ. Given this information, the ACOG-MFM guideline recommends antenatal steroids be administered to mothers with concern for delivery beginning at 23 weeks gestational age. The next study we'll discuss is a meta-analysis by BACS, which included studies reporting on infants born at 22 weeks gestation who received proactive treatment, such as intubation, compressions, and epi. Any studies where treatment was directed to comfort care were excluded. In total, 31 studies were included in the analysis, giving insight into over 2,022-week births. The pooled survival was 29% across all studies. However, the survival among infants whose mothers were treated with antenatal corticosteroids was double that of infants who did not receive antenatal steroids. The second study by Arid and colleagues was a multi-center observational cohort study looking at over 29,000 infants born between 22 and 25 weeks gestational age. They looked at outcomes associated with the receipt of antenatal steroids and found that both survival to hospital discharge and survival to discharge without major morbidities was higher in the steroid-treated group. So antenatal steroids are recommended for women between 24 weeks gestation and 36 and 6 weeks gestation who are at risk for preterm delivery. Steroids may be considered for 22 and 23 week infants depending on the family's wishes surrounding resuscitation. Betamethasone or dexamethasone may be administered to the mother in the doses shown on the screen. Current literature really doesn't consistently suggest one steroid agent over another, so both are considered adequate per ACOG at this time. Practically, betamethasone is less frequent administration, and since these are administered as intramuscular injections, it's likely preferred from a patient comfort standpoint. In regards to other therapies, the group recommends maternal administration of magnesium sulfate for neuroprotection, given a smaller study that showed a reduced incidence of cerebral palsy without an increase in mortality in those less than 30 weeks gestational age. This study enrolled infants down to 24 weeks, so the study was not specific to the periviable or micropreemie population. Antibiotics should be considered in the setting of prolonged or premature rupture of the membranes for those 24 weeks and older, but no data exists currently to suggest for or against antibiotic therapy in those infants born less than 24 weeks gestation. In regards to tocolytics, while they may prolong pregnancy, improvements in neonatal outcomes have not been demonstrated. Therefore, no recommendation is made by the group at this time. In general, most of these interventions are not necessarily recommended less than 23 weeks gestation, appropriate for consideration at 23 weeks gestation, and then recommended for use at 24 weeks gestation and above. So moving on into postnatal management, this data is primarily extrapolated from the management of older preterm infants. We'll start by talking about respiratory distress syndrome, which is diagnosed in nearly all infants born before 28 weeks gestational age. Micropreemies may have a delayed presentation, but they will develop RDS. Surfactant deficiency leads to an increased surface tension in the alveoli, resulting in atelectasis and low lung volumes. Pulmonary edema also contributes to the pathogenesis of RDS, and due to this, RDS typically improves once diuresis occurs postnatally. Signs and symptoms of RDS include tachypnea, grunting, nasal flaring, and retractions. Respiratory distress management can be broken down into preventative and treatment. Prevention includes antenatal corticosteroids, which we already discussed, and treatment involves replacing the surfactant which these infants are deficient in. Antenatal corticosteroids have been shown to have a survival benefit down to 22 weeks gestational age. They accelerate fetal lung maturation in the preterm population and have been linked to a reduction in respiratory distress and moderate to severe respiratory distress and the need for mechanical ventilation in the first 48 hours of life. Despite these short-term benefits, they have not shown an impact on reducing BPD, likely due to increasing survival of these infants who are already at a high risk of developing BPD. A 2015 study looked at trends in care amongst infants born 22 to 28 weeks gestational age, and over a 10-year period found a significant increase in antenatal steroid use. In that same time period, the number of infants intubated in the delivery room decreased, and non-invasive respiratory support use increased. The impact on those periviable infants in regards to respiratory outcomes is a bit unclear. However, the structural changes that are taking place during this period are known to be accelerated by steroid exposure. Results of animal studies suggest that human lungs should respond to steroids during the periviable period. In the Carlos study that we discussed previously, they demonstrated a survival benefit, but did not demonstrate any benefit in chronic lung disease or BPD in this population. A study from Japan had similar results for both survival and respiratory morbidities. Given the literature to date, ACOG recommends steroids beginning at 24 weeks, but may be considered in the 22 to 23 week group. Literature has shown that surfactant therapy reduces mortality, pulmonary air leak, and the risk of death or BPD. However, not all infants will need surfactant therapy. Mild cases may respond to CPAP alone, but severe cases do require administration of exogenous surfactant and/or mechanical ventilation until the endogenous surfactant production begins. Although prophylactic administration isn't widely recommended due to potential overtreatment or unnecessary treatment, earlier administration does show better outcomes than late administration in those with established RDS who need surfactant therapy. Adverse effects of surfactant administration include bradycardia, oxygen desaturation, hyperoxia, and blockage of the endotracheal tube. Both animal-derived and synthetic surfactant therapies are available. However, animal-derived surfactants are associated with lower mortality rates and fewer pneumothoraces. Here on the screen, you will see the available animal-derived agents: Baractant, calfactant, and poractant. Each of these agents is administered endotracheally. For Baractant, each of the 4 doses is administered with different positioning. Slightly downward incline with head to the right, then repeat with head turned to the left. Then slightly upward incline with head to the right and repeated with head to the left. For those babies at risk of IVH, which is our micropreemie population, keeping the head midline and avoiding changes in positioning is ideal to reduce the chance of a bleeding event. So Baractant's administration technique really limits its use in the micropreemie population. Many studies do not show preference to one surfactant therapy over another. However, there is some literature in the smaller preterm populations to suggest there may be a benefit of Baractant in this population. Ramathan compared proractin and boractin in patients around 28 weeks gestational age with a mean birth weight around 1150 grams. They found that the proractin group had a lower oxygen requirement and required fewer repeat doses than the boractin group. Interestingly, they also found that in those patients born before 32 weeks gestational age, there was a lower mortality in the proractin group. Fuji and colleagues did a similar comparison of agents in a slightly younger and smaller population and found that the proractin group had a lower mean airway pressure requirement and earlier extubation compared to the boractin group. Despite the short-term benefits that they saw, there was no difference in the rate of BPD between the two groups. The final study that we'll discuss included 126 preterm infants who received boractin or proractin and found, similarly to the two prior studies, that the proractin group required fewer repeat doses, had higher extubation rates, and lower FiO2 requirements. Additionally, this study showed that survival free of BPD was higher in the proractin group. So in summary, regarding respiratory distress syndrome, micropreemies may have a delayed presentation of RDS compared to older infants, but be certain it is coming. Studies have failed to show a clear benefit of antenatal corticosteroids in the development of BPD in those born at 22 to 26 weeks gestational age. And finally, if surfactant therapy is needed in infants less than 26 weeks gestational age, proractin alpha may be preferred due to the mortality benefit, lower FiO2 requirements, earlier extubation, and then the administration technique. Moving into our next section, we will begin talking about apnea of prematurity. So apnea of prematurity is one of the most common diagnoses in the NICU population. The incidence is higher with lower gestational ages, with nearly all infants born less than 28 weeks being diagnosed with apnea. Apnea is defined as a cessation of breathing for at least 20 seconds or a shorter pause in breathing that's accompanied by bradycardia, cyanosis, or pallor. The etiology of apnea can be central, which is defined as a cessation of breathing, obstructive, which is due to an obstruction, typically at the pharyngeal level, or a mixed presentation that combined both central and obstructive features, which is what we see in most of our preterm infants. Generally, these apneic events resolve around 36 weeks gestational age. However, those born at earlier gestational ages take longer to resolve. Infants born between 24 and 26 weeks gestational age are more likely to have events that persist beyond term-corrected gestational ages. Methylxanthines have been the mainstay of pharmacologic therapy for apnea of prematurity, with caffeine being preferred over theophylline due to its longer half-life, larger therapeutic index, and the lack of a need for therapeutic drug monitoring. Methylxanthines prevent apnea through inhibition of adenosine, which leads to increased respiratory neural output, ultimately leading to an increase in minute ventilation, improved carbon dioxide sensitivity, decreased periodic breathing, and improved skeletal muscle contraction, which improves contractility of the diaphragm. Dosing is typically a 20 milligram per kilogram loading dose, followed by a maintenance dose of 5 to 10 milligrams per kilogram per day. Adverse effects to be mindful of include tachycardia, emesis, and jitteriness. One of the most well-known trials we have in neonatology is the Caffeine for Apnea of Prematurity, or CAP trial. They enrolled 2,006 infants with a birth weight between 500 and 1,250 grams if they were deemed eligible for methylxanthine therapy within the first 10 days of life. The caffeine-treated group had a median birth weight of 964 grams and gestational age of 27 weeks. So while this study did include some of the micropreemie populations, they were likely underrepresented here. The study population was greater than or equal to 25 weeks and greater than 700 grams. Patients were randomized to either the caffeine or placebo arms, with the caffeine arm receiving a 20 mg per kg load, followed by 5 mg per kg per day maintenance, which could be increased to 10 mg per kg per day if apnea persisted. The study authors found a significantly lower incidence of BPD in the caffeine-treated group, but no differences seen in death, ROP, or NEC. They also looked at growth between the two groups, and while at 3 weeks post-randomization, the infants in the caffeine group had gained less weight, there was no difference seen at the 6-week observation. The median age at extubation was 29 weeks in the caffeine group compared to 30 weeks in the placebo group, with last supplemental oxygen used around 33.5 weeks versus 35 weeks in the placebo group. So we're looking at about a week less of intubation and oxygen in the caffeine-treated group. If you have children at home, you've probably seen Encanto, and this picture makes sense. For those that haven't, the song that's playing in the background here stops and says, "And that's why coffee's for grown-ups." In our case, we're talking about grown-up preemies. We've seen the benefits of caffeine use in our older premature infant population, but can we safely and effectively use caffeine for the same benefits as in our older premature population, and how do we go about this? A few questions remain to be fully answered, including when do we start therapy, what's the optimal dose in this population, how long should we treat them, and is there any need to be concerned about GI perfusion changes with caffeine boluses? When discussing timing of caffeine therapy start, the CAP trial administered doses within the first 10 days of life. In this study, the authors did a subgroup analysis comparing the groups, and they looked at caffeine initiated before 3 days of life and those who started on caffeine after 3 days of life. They found that earlier initiation was associated with earlier extubation and earlier age to no longer require positive pressure ventilation. However, there was no difference in BPD, death, cognitive delay, cerebral palsy, or the last oxygen use between the two groups. Dobson and colleagues looked at outcomes associated with early caffeine administration using a multi-center data set. Their data set did include younger patients. The 5th percentile in the early group was around 25 weeks, and the 5th percentile in the late group was around 24 weeks gestational age. So some of our micropreemie population was represented. They found early administration to be associated with decreases in death, BPD, and the combined outcome of death or BPD, as well as a shorter duration of mechanical ventilation. Like the CAP trial, while these studies did include younger and smaller patients, the mean age and birth weight of these study populations were older and larger than our micropreemie group. Some speculate that the same effects would be apparent as was seen in the older infants, but this has yet to be shown in studies that actually looked at these particular patients. So there is concern of reduced blood flow following caffeine administration and its relation to the development of necrotizing enterocolitis. Caffeine inhibits adenosine-induced vasodilation, and endothelin-dependent and independent vasoconstrictions have been reported in canine superior mesenteric arteries, which may be responsible for reduced blood flow velocity following caffeine administration. There are a few small studies that have looked at blood flow in the superior mesenteric artery, which we'll look at. The first study looked at 12 preterm neonates with a median gestational age of around 31 weeks following a caffeine load of 50 milligrams per kilo, which is much higher than was used in the CAP trial. They found that peak velocity in the SMA was significantly reduced for 6 hours after administration of the caffeine bolus. The next study looked at 38 preterm neonates who fell between 28 and 33 weeks gestational age who were given a 20 milligram per kilogram load, which is consistent with the CAP trial recommendations. They found a reduction in peak systolic velocity at 1 hour post-dose and a reduction in end diastolic velocity at 1 hour and 2 hours post-dose, an increase in the resistive index at 1 hour and 2 hours following the caffeine dose. Despite the changes seen following the bolus dose, they found no effective maintenance caffeine dose on blood flow velocity in the SMA. The next study looked at 18 infants with a mean gestational age of around 28 weeks, following a 10 mg per kg load and blood flow velocity decreased by 18% at 1 hour and gradually increased towards the baseline values by 6 hours after caffeine administration. The study also looked at clinical endpoints rather than just blood flow velocity changes and reported that no infants developed NEC. The last study I have here looked at 16 preterm neonates who were given 12.5 mg per kg loads times 2 doses, which were given 4 hours apart. So essentially a 25 per kilo load that was split, and found that blood flow velocity in the SMA was unaffected by this dose. So based on these small studies, it appears that doses that are 20 to 50 mg per kg may alter blood flow velocity, but smaller doses of 10 to 12.5 mg per kg do not significantly alter blood flow in the superior mesenteric artery. Currently, there's not enough data to say that these doses or changes in blood flow velocity correlate to NEC risk. However, it is something to be mindful of in the micropreemie population. So while caffeine is one of our most commonly used agents in the NICU, the question of dosing, particularly in the micropreemie population, has yet to be elucidated. So population PK modeling performed after administration of caffeine doses to 119 neonates found that the preterm population had a higher volume of distribution than what's been reported in the term infant population. But infants born less than 28 weeks had a lower volume of distribution than those born after 28 weeks gestational age. Due to these pharmacokinetic differences, lower doses of caffeine were required to reach steady state levels. Other studies suggest differently. An article published last year in the Journal of Perinatology found that infants born at earlier gestational ages, including down to 24 weeks, required higher maintenance caffeine doses for apnea control. It's unclear if this is fully due to pharmacokinetic differences or a higher apnea burden in the more premature population. As I mentioned previously, those born at earlier gestational ages take longer for their apnea and bradycardia spells to resolve. Infants born 24 to 26 weeks gestational age are more likely to have events that persist beyond 38 weeks corrected age, and likely the same goes for those who are born at 22 and 23 weeks. The CAP trial treated infants until 34 weeks corrected age. However, they didn't include infants less than 25 weeks. So the question remains, how long should we treat these babies? Should we stop at 34 weeks or should we continue on, particularly if they're having spells? It's a question that remains unanswered, but in clinical practice at my institution, we'll often keep infants on caffeine beyond 34 weeks if they continue to have true apneic events, and particularly if they still require positive pressure ventilation at 34 weeks gestation. Moving into our last section of this talk, we're going to move into talking about nutrition management of these small babies. So as in many of our NICU babies, maintenance fluid requirements are dependent upon insensible water losses, which generally have an inverse relationship with their gestational age, excretory losses through urine and stool, and water retained for growth. The ideal amount of water provided should allow for natural diuresis, where we expect around a 10% weight loss, while avoiding hypernatremia. In the micropreemie population, their insensible losses are the primary driver of their maintenance fluid requirements. A higher fluid intake and less weight loss in the first 10 days of life has been associated with an increased risk of BPD, PDA, and NEC in the extremely low birth weight population. Additionally, when working with immature kidneys, that brings on another level of complexity to management of fluid and electrolyte balances in these patients. Limited data exists to guide fluid management in those less than 25 weeks gestational age. However, based on some small studies that are available, there is some guidance on how to initiate fluids and electrolytes in this population. Given that insensible water losses vary based on environment, the guidance differs for those infants in a humidified incubator compared to those in radiant warmers. These proposed ranges are for infants with no significant catabolism in the first couple of days and take into account insensible losses, urine output, renal solute load, as well as their expected weight loss. The authors suggest little to no additional sodium in the first 48 to 72 hours of life, but note that complete sodium avoidance isn't possible since so many of our medication carriers, flushes, or infusions for line patency all contain some amount of sodium. Beyond the third day, sodium should be added based on the baby's basic metabolic panel to prevent depletion of total body sodium. Urine output should be established prior to the administration of potassium, and electrolytes, urine output, and weight should be monitored closely in these early days, and fluids and electrolytes adjusted appropriately. Extremely low birth weight infants are born into a state of what would normally be described as malnutrition. Many of our key nutrients, like calcium, phosphorus, iron, vitamins, fat, and glycogen, all accrue during the third trimester of pregnancy, which these infants miss when they're born less than 28 weeks gestation. Additionally, many of these babies have a suboptimal intrauterine environment and are more likely to be small for gestational age. Current guidelines for nutrition in the ELBW population as a whole recommend early nutrition with higher caloric goals and protein intake, which has been shown to reduce mortality, BPD, length of stay, and improve neurodevelopmental outcomes. Unfortunately, providing aggressive nutrition to a malnourished patient can precipitate refeeding syndrome. While there are no firm guidelines or diagnostic criteria for neonatal refeeding syndrome, what we sometimes see in these infants is very similar to what we see in the older population. This is thought to be precipitated by intravenous amino acids and glucose administration, which stimulates endogenous insulin secretion and the transfer of phosphate from the bones to the cells for energy production. Without sufficient electrolytes to meet the demands, we see this metabolic disruption set in around 2 to 5 days after initiation of nutrition, which we call refeeding syndrome. Neonatal refeeding syndrome has been associated with metabolic acidosis, hypernatremia, hypovolemia, ischemia, respiratory alkalosis, delayed enteral feeding, sepsis, and chronic lung disease. This is a common phenomenon in the ELBW population, and infants that have intrauterine growth restriction and insufficient placental nutrient supply are at highest risk of exhibiting this refeeding-like syndrome upon aggressive initiation of TPN. Sung and colleagues conducted a retrospective single-center chart review comparing initial amino acid dosing in ELBW infants. Low-dose administration was 1.5 grams per kilo per day, and high dose was 3 grams per kilo per day. 142 infants were included in the study. Given the risk of hypophosphatemia in small for gestational age infants, the group was subdivided according to SGA and appropriate for gestational age groups. The authors found that hypophosphatemia was higher in the SGA infants, and the SGA group had a significantly higher rate of hypophosphatemia in the high-dose amino acid group as compared to their AGA counterparts. Overall, early high amino acid administration and SGA increased the risk of severe hypophosphatemia and led to a recommendation by these authors to offer a tailored approach to nutrition, including lower amino acids in this population. Another multi-center study from 2020 explored relationships between refeeding syndrome and other factors in ELBW infants. Neonatal refeeding syndrome was defined in this study as hypophosphatemia and hypercalcemia. The authors found that refeeding syndrome was higher in SGA infants and that glucose, amino acid, and total energy delivery was higher in the group with refeeding syndrome, which calcium, phosphorus, and sodium delivery were lower in this group. Additionally, mortality was 3-fold higher in infants with refeeding syndrome as compared to those without, which speaks to the importance of understanding and preventing this phenomenon in our smallest patients. In summary, Micropreemies require increased fluid delivery, enhanced monitoring of electrolytes, particularly in the first week of life, optimal calcium and phosphorus delivery, and lower and slower delivery of amino acids and glucose. So pharmacists in the NICU can play a vital role in many aspects of care related to the micropreemie population. Pharmacists can be involved in making nutrition and fluid recommendations and can help to come up with creative strategies to reduce fluid and sodium intake, particularly when it's most critical in the first few days of life. Pharmacists are also essential in selecting preventative medication therapies, helping with medication dosing where literature is lacking, developing patient-specific medication therapy plans, and development of protocols or order sets to serve this particular population. Now we come to our review questions. Our first question: infants born at less than 26 weeks gestation are at higher risk of which of the following complications? BPD, HIE, NEC, A and C, or B and C? Question 2. Which of the following has not been shown to be a benefit of antenatal corticosteroid administration for infants born at 22 to 26 weeks gestation? Decreased IVH, improved survival, decreased NEC, decreased BPD, or improved neurodevelopmental outcomes? So answer D is correct. Despite the multiple benefits that we've seen with antenatal steroid administration, it's not been shown to decrease the incidence of BPD. Question 3. As the NICU pharmacist at your hospital, the team asks that you review the animal-derived surfactants to select a formulary product for use in infants born before 26 weeks. Which of the following should be considered in your formulary review? Cost, method of administration, mortality benefit, volume to administer, or all of the above? So all of the above are important considerations in completing a formulary review. Question 4. Baby A is a 23 and 2 week infant newly admitted, and the team consults you for help with selecting a caffeine regimen. The team wants to administer caffeine for BPD reduction, but they're concerned with a possible change in GI perfusion following the loading dose. Given the literature reviewed, which of the following is the most appropriate regimen to balance BPD benefit while avoiding a decrease in GI perfusion? So a 20 mg per kg load followed by 5 mg per kg per day, a 20 mg per kg load on day of life 4 followed by 5 mg per kg per day, a 10 mg per kg load on day of life 2 followed by 5 mg per kg per day, or no load and just start maintenance of 5 mg per kg per day. So for this question, I think option A or option C could be argued as appropriate options. So for option A, the dosing represented is consistent with what was used in the CAP trial, which showed a benefit in reducing BPD. However, as we talked about, the infants enrolled in this study were older with a median gestational age of 27 weeks, and their first dose wasn't given until around 28 weeks gestation. So while we can extrapolate and hope that the same benefit would be seen in those less than 26 weeks, we don't have data to confirm or deny this at this time. Option A wouldn't be inappropriate, particularly when referring to BPD prevention, but the GI perfusion question remains. For option B, I wouldn't delay greater than 3 days from birth at this time to start the caffeine load. I think the literature that is available all supports early administration of caffeine, so I wouldn't do day of life 4 administration. For option C, given the concerns of GI perfusion, there is a small amount of literature that's looked at caffeine loading doses in GI blood flow, and have found that doses of 20 mg per kg and 50 mg per kg alter blood flow, but the same was not seen for lower doses of 10 mg per kg and 12.5 mg per kg. Day of life 2 is still within the less than 3-day window where we think there's the most benefit. Again, extrapolating due to a lack of literature specific to our population. But there's nothing to confirm really or refute that 3-day timeline. And then option D, you could consider not loading since this baby is unlikely to be ready for extubation, but no studies have evaluated this regimen for its benefit with BPD. So I would not recommend that at this time. And lastly, baby G is a 22 and 6-week infant born this morning by urgent C-section due to severe maternal pre-E. She has intrauterine growth restriction with a birth weight less than 5th percentile for age. She's voiding appropriately, and the team consults you for ordering the parenteral nutrition. Which of the following is an appropriate consideration for baby G's day of life 1 nutrition solution? A fluid delivery goal of at least 100 mL per kilo per day. B, amino acids at 4 grams per kilo per day. C, sodium at 3 milliequivalents per kilo per day. And D, hold phosphorus given concern of renal immaturity. So A is the appropriate answer here. Remember, these babies have higher fluid requirements due to higher insensible losses. So fluid should be a minimum of 100 mLs per kilo per day. Since she's growth restricted and a 22-weeker, she's at high risk of refeeding syndrome, so we would not want to deliver goal amino acids this early. Additional sodium as an answer C could also be harmful by delaying diuresis and increasing BPD risk, so we try to avoid that until around day of life 3. And finally, while we should be considerate of renal immaturity and phosphorus delivery, remember that these babies need phosphorus and have missed that good delivery from mom that occurs in the 3rd trimester. So while we don't give them high doses, they should receive some phosphorus, particularly if they're at risk of refeeding syndrome. So micropreemies are likely to suffer from long-term complications if they survive the newly born period. They have specialized care needs that should be considered, including nutrition delivery, caffeine delivery, and surfactant therapy selection. Many therapies utilized for premature infants are not studied in the 22 to 24 week population, and further study is needed to characterize the safety and efficacy in this patient population. Finally, nutrition support is challenging, and there's not a lot to guide us in what to do and some conflicting information. So we need to be monitoring these patients closely and adjusting as needed to meet their needs. Thank you for your time and attention. I hope you enjoyed this presentation.